in a nursing home setting. This is brought to you by Qsource ESRD Networks 10 and 12. So as we go through the slides, I do have just a few housekeeping items that I wanted to share with you. Roma, could you please advance the slide? Thank you. Just as a heads up, the Teams is a little different than how we're accustomed to doing our webinars, so bear with us for a moment. As you joined our session today, we're trying to mute everyone to reduce the level of background noise.
Can be adapted to meet the needs of the dialysis facilities, patient payers, and the network.
Perfect example. There was a little bit of background noise, so we tried to mute those. That doesn't mean that we don't want to participate with you throughout the webinar. So if you do have a question, please do use the conversations bubble. It is located at the top of your screen, probably. Or you could raise your hand and we'll try to converse back and forth. And I'll try to do things behind the scenes. Let's go to the next slide.
No, not yet. 5.
All right. I just wanted to share a little bit about the ESRD network program in general. The program started in the 70s. We are contracted, the ESRD networks are contracted by the Centers for Medicare and Medicaid Services. There are 18 of the networks across the nation.
All right, I'm on. We're here.
Hello, hi.
Just starting. Cool. You know what?
I am hearing some background noise. Let me see if I can find a way to mute that line. All right. As I said before, we're trying to make sure that some lines are muted to reduce the level of background noise, and you always have the option to unmute yourself. Anyway, to get back to the ESRD Networks program, the country is broken up into 18 regions or individual 18 networks. Networks 10 and 12 are on the line. We're the ones who are facilitating this call. 10 is the state of Illinois, and 12 is the 4-state region of Kansas, Missouri, Iowa, and Nebraska. However, if you're interested in learning more about your local network, you can always go to their website or to the ESRD Network Coordinating Council, esrdncc.org. Next slide, please. Just a real quick thing that we wanted to share with everybody. Earlier this year, we had collaborated with our Quality Innovation Network Quality Improvement Organization to create and encourage the use of a communications form. The intent of this was to be a bi-directional communication form for both long-term care and dialysis facilities. It's to address patient-specific and facility-level updates. It's intended to be completed prior to a transfer and with the expectations that there are follow-up communications as needed and as required. That is available on the website, and the hyperlink is available for you, and it will be included in the PowerPoint presentation at the end of this session. Next slide, please. We'll go over a little bit of the goals today. The goals are to learn about the importance of dialysis for a nursing home resident, understand the advantages of on-site dialysis, review responsibilities of long-term care and dialysis facilities according to CMS requirements and NDAC standards, recognize the benefits of care transitions in improving outcomes. Next slide. We are joined today by 3 amazing individuals. These are our speakers for our educational session. We will introduce each one of these individuals right before their session. We are joined by Dr. Suresh Sampson, Shirley Irvin, Linda Payne. We are going to start with Dr. Sampson's presentation, and let me just read to you his small bio. Dr. Sampson is a practicing nephrologist in Chicago. He has been the Chief Medical Officer of Concerto Renal Services since 2014. He attended medical school in India, has trained in the United Kingdom, and after that, he did a residency at Yale Bridgeport Hospital in Connecticut with a fellowship in nephrology in Milwaukee. Thank you so much, Dr. Sampson. I will turn it over to you.
Right, thanks, Payne. Hey, I'm Dr. Sampson. As Payne said, I'm the Chief Medical Officer for Concerto Renal Services. And Concerto Renal Services is a company which exclusively does dialysis in nursing home settings. So I have a good amount of experience with SNF and SNF dialysis for the last many years. With that, I'll go to the next slide, Roma. And so today we'll discuss quickly about the problem at hand and the opportunity that the problem gives us. And then I'll spend a lot of time on discussing about the benefits of having dialysis in the SNF and the benefits to the SNF and to the patient. So I'll spend a lot of time on that. So next slide, these are data from USRDS, which is the database which collects information about dialysis patients throughout the country. Roughly around 700 or more than 700,000 dialysis patients in the country as of now. The estimate is out of these, 10%, that is roughly around 70,000 of them reside in nursing home facilities. So these are dialysis patients who are in the SNFs. The last point is to give an idea about which patients are mostly in the nursing home. There are 700,000 patients. Of the 700,000, 80,000 of them do dialysis at their respective home, and either on their own or a family member is helping them. These patients are not in nursing home. These are at their home doing dialysis. So when a nursing home is looking at a dialysis population in an area, you are still mostly looking at those majority of patients who get dialysis in a dialysis center. So in the entire country, nearly 90% of the country is doing dialysis in a center. So from a nursing home perspective, those are the population who SNF is going to be seeing as their inpatient when you do dialysis. Now, there are a few regulatory changes that happened that made this dialysis in SNF more attractive to both SNF, the patient, the hospitals, the whole health system. And Glenda would later go into detail about these things, but I'll touch a few of those. In 2004, CMS, which is Center for Medicare and Medicaid Services, which puts out lots of most of the regulatory framework for dialysis, came out and said that, for the purpose of dialysis, any skilled nursing setting where the resident is considered their home, the resident's home. So for that reason, any dialysis that happens in the skilled nursing facility is called home dialysis versus an in-center dialysis, which most of the patients do outside of the SNF. And then in 2018, for the first time, CMS came out with a framework, a regulatory framework, to lay down some specifics about how SNF dialysis is looked at and who the parties are, what the responsibilities are for the SNF in terms of having dialysis inside the SNF, and what are the responsibilities are for the dialysis provider who works along with the SNF to provide dialysis, and the coordination that needs to happen between two, and I'm sure Glenda will go in detail about that as well later. And then the last point I have, Roma, I have one more point on that slide, if you can. You can click next and we'll get another point. Yeah. So then from a SNF perspective, the change that happened recently within the last 2 years is the implementation of a patient-driven payment model, which I'm sure most of the SNF providers and administrators on the call would be familiar with. And that put a lot more emphasis on the acuity of care that's provided to a patient rather than the number of services that are being provided. And dialysis patient falls right into that category of being a high acuity patient. And that's how we're going to be discussing going forward as to what the benefits are to the nursing home. So next slide. And this is just a picture of a dialysis unit inside a nursing home, pretty much similar to any dialysis unit outside. And this is what's called a den model, where there is a space in the nursing home which is converted into a dialysis space. And over the next 2 slides, we'll talk about how a nursing home can think about and make a decision about how, when, and where should they start dialysis in the nursing home. So yeah, next slide. Yeah, go ahead, click again, Roman. So the decision to start dialysis from a SNF perspective, how do we start? How does a SNF start thinking about dialysis? Now, the place to start would be looking at their nursing home dialysis census. You would know how many dialysis patients have been there in the nursing home over the last year. Gives you an idea about what to expect if you have a dialysis unit in place. And then next click, Roman. And then you can have conversation with the hospital leaders or case managers and prominent nephrologists in the area. They can give you some input about how many patients are there that are being discharged from the hospital who are on dialysis, who go to a nursing home. Gives you some idea about assessing your census, future census when you're thinking about starting a dialysis unit. And with starting a dialysis unit comes, taking more risks, and that is, training the nurses, nursing home nurses, about the basics of dialysis, so they understand how to take care of the dialysis patient, because these dialysis patients are going to stay in-house, do dialysis in-house, come back to their room. It's just that communication and what to look for, and those are the basic education nurses go through. This is an advancement of their education, which is easy to do, and many times dialysis providers like Qsource can help do those things. And it also helps provide the infection control policies the nursing home has, to expand that or extend that to the dialysis units as well, help keep patients safe when they're getting dialysis. And the last thing is obviously how much is it going to cost, what the expenditure is, and all these play a role into first deciding whether a nursing home should think or start about dialysis. Now, a nursing home can go do all these things, look at all these data, make an effort to get these data, and then maybe call a dialysis provider like Qsource, say, hey, you know what, we're thinking about doing dialysis. Can we start talking? Can we go from here? Or the other way to do it is, without getting these data, just give a call to a dialysis provider like Qsource and ask, hey, we're thinking about it. How can we go about it? The chances are the dialysis provider already has some market analysis in your area and would be able to guide you in a better way to go forward from here. Once we've started thinking about having dialysis, then one of the big questions we need to consider is what type of dialysis. I'll give you a brief overview of the types of dialysis, and then about the specific types that are suitable for a SNF facilities. So there are 2 types of dialysis in general, which is peritoneal and hemodialysis. Peritoneal dialysis is done through the belly. You have a catheter in the belly. The patient does it mostly at home at night when they are sleeping with the help of a small machine and some bags of fluid. So you get some fluid in the belly for a couple of hours, drain it after a couple of hours, put some more in, does it 3 or 4 times when you're sleeping. When you wake up, you're done with dialysis, and that's peritoneal dialysis.
Here he is.
The other type of dialysis that's done is hemodialysis, which is taking blood out of your body, clean it through the dialysis machine, send it back to the patient. And that is the common type of dialysis done in this country. If you remember my first slide, nearly 90% of patients who do dialysis do hemodialysis. So majority of the population a SNF is going to see is going to be a hemodialysis patient. So most of my presentation is going to be tailored more towards a hemodialysis patients, as even in my experience, it's very rare to see a peritoneal dialysis patients come through. The volume is not going to be great. So I'm going to be concentrating more on hemodialysis patient in terms of from the SNF perspective. And even when you take hemodialysis, there are two ways of doing hemodialysis. One is a 5 days a week and dialysis, and the other one is 3 days a week. And so you may ask, what's the difference? So most of the data we have to look at differences between the two types of dialysis is done outside the SNF. The studies are done in regular patients outside who are a little more healthier than the nursing home patients, as you all know. So what that data does suggest is that the 5 days a week dialysis may offer a little longer survival, and the patients who do it feel better than 3 days a week dialysis. And we don't have a lot of data whether that is actually true for nursing home patients. This is important to understand. My personal belief is these are a lot more sicker patients than the outside world, and I doubt there will be any difference in terms of survival or anything with these two different modalities, and we still would need some studies to even see if there's going to be a difference. So before I start about the other differences as for SNF, from the SNF, the other differences, I'll talk about some similarities between the two types of dialysis. And the similarities would be related to the space that's needed. Irrespective of what 5 days a week, 3 days a week, the nursing home is going to pick up a space, either a previously used gym or a space that's never been used in the nursing home. You decide the space, and both the types of dialysis are going to need space to do dialysis. Roughly to give an idea, if there is a dialysis unit, you're planning for 6 dialysis chairs in the unit, we're talking about somewhere around 300 square feet space, 250 square feet space, and then a lot smaller space for storage. And that's the similarity for the two types of dialysis. And then the similarities end. There are lots of differences that the SNF has to consider between deciding which type of dialysis we choose. And go to the next click, Roma. And one of the biggest differences is the capacity. Now, I'll explain this by a simple example. So if we assume that we decide on doing a dialysis unit with 4 chairs, when we do 5 days a week dialysis with 4 chairs, our maximum capacity with 3 shifts a day would be 12 patients in total. So the capacity is limited at 12. When we do 3 days a week dialysis, the capacity almost doubles. So you could dialyze up to 24 patients with the same 4 chairs. And this we have seen here and there that the capacity became a problem during the COVID surges when patients had to be moved to the nursing homes, that their capacity was an issue. So as far as capacity is concerned, there will be a chance to increase capacity pretty rapidly in 3 days a week dialysis compared to 5 days. Next click, Ron. And then continuity of care. This is, again, a very tricky part as far as dialysis patients are concerned. Again, 90% of patients in the country are being dialyzed 3 days a week. So you take that patient, you send them to a SNF, and it's important to continue their care and do the same 3 days a week dialysis. Then once the patient is ready to be discharged, they go back to their 3 days a week dialysis in their outside nursing home. And that's a good continuity of care, and the patients usually don't see anything different in that. It becomes a little difficult to convince a patient to do someone who's done 3 days a week dialysis for 2-3 years now to send them to a nursing home and say, hey, you know what, 5 days a week dialysis could be better for you. Let's do it for the next 2-3 weeks you're here and go back to the usual unit where you would go back to 3 days a week. It does disrupt the continuity of care. Some patients are good with it. It's based on an individual basis. Some people are okay with it. Some patients do not like that change and they want to stick with 3 days a week. Again, things that the SNF has to be looking into what they think. Communication with their local hospital and their nephrologist will really help understand what the patient needs are in that community. Next click, Ron. And then lastly, the startup cost. And there is going to be obviously a startup cost for setting up a dialysis unit. You're going to find the space, you're going to make some improvements to the space, you're going to need water supply to that space, and electrical outlets, sink. There is going to be a startup cost. But along with it, it does bring a lot of value. So my experience in discussing with Concerto and their discussion with nursing home providers, when we look at this startup cost along with the value that brings in and the revenue that's going to bring, then it's easy to see how the startup cost really is not going to be a big deal in the long run. And it's hard. The startup costs vary depending on a lot of things, and depending on how big the dialysis unit is going to be, how many chairs we're going to have, urban, suburban areas, and staffing costs, and all this. It's going to vary. It varies largely between anywhere between say 30,000 to 200,000. So it really needs to be worked out on an individual basis between the SNF providers and the dialysis providers as to what the costs are going to be. And then we touched a little bit on the patient preference already. Again, same thing with, would the patient in that community prefer 3 days a week dialysis, or would they want to do 5 days a week dialysis? And what kind of a population we have that we are expecting when we start dialysis. Again, the dialysis provider might have some information for you already about this, but the local hospitals will be happy to help you, or the nephrologist will give you some idea about that. Slide. Go ahead, please. That is about how to make a decision about dialysis. So in terms of benefits to the nursing home, once you start dialysis, what are the benefits to the SNF that we're talking about? And one of the framework for regulatory framework CMS put out, they emphasize a lot on coordination of care. We're going to have a dialysis provider, we're going to have a nursing home provider, we're going to have a nephrologist. The emphasis is on a lot of coordination. And think about this. It is a lot better to have good coordination between the dialysis unit and the nursing home if the dialysis unit is in-house, rather than a dialysis unit somewhere outside. And that leads to preventing admissions to emergency rooms, or preventing readmissions to the hospital. And I'm sure there are some SNF administrators here who would know, when a patient goes from a SNF to a dialysis facility, how many times they end up in an emergency room from the dialysis facility, and then the SNF knows about it later. So now in this model, you have the dialysis unit inside the SNF. The patient is always going to go to a hospital only through the SNF. The SNF has a better control and oversight over where the patient goes from dialysis and how the patient does on dialysis. There will always be communication between dialysis unit and SNF on a daily basis as to how patients are doing. Good, gives a better control on patient care. And something that needs to be mentioned in the COVID era is about the infection control. Again, patients are not going outside the SNF facility. They're not getting to see more emergency ambulance personnel, or they don't get exposed to dialysis unit staff outside the facility. So a lot better way to control infection. And also having a dialysis unit inside the facility gives you an opportunity to communicate with them very frequently and pass on information that you know about infection control. There would be patients who are 3 COVID patients and 2 MRSAs and 2 C. diff patients. It's easy to communicate that to the dialysis unit, so dialysis units can work with you to change the way they do dialysis and prevent the infection from spreading. Which I think from Concerto standpoint, we've been able to do it very well. The whole time we had COVID, we were able to do a separate shift for COVID, a separate shift for COVID PUIs, and a separate shift for people who don't have COVID. work very well. And again, last thing, an opportunity to involve the dialysis provider in your monthly quality improvement projects, or not projects, in your QAPIs. So you can hash out some of the problems or some of the things that you're doing very well, and keeps the coordination of care going. And the last thing I want to talk about is the financial benefits. And you already might have figured out, like, not having having a dialysis unit in the SNF eliminates the transportation costs. Right now, most nursing homes, you can go to the next slide, Roman. Right now, most of the nursing homes have to send this dialysis patient 3 days a week to an outside dialysis facility, through a Medicard, through an ambulance. And there are some states which do require that SNFs send a full-time staff along with the patient through dialysis. So this cost can be totally avoided when you have a dialysis unit on site. And you can reduce the healthcare expenditure. Obviously, the name of the game these days is being more efficient, reduce the cost. That's the name of the game. So big reduction in cost for dialysis patients. And obviously the health system, and in the SNF world, the hospitals are going to start noticing it. And now that makes the SNF more like a partner for the nursing home, for the hospitals, rather than someone who's a downstream provider for the hospital. And it puts you at a level where now you can go to the hospital and discuss about reducing the hospital stay, reducing readmissions to the hospital, and reducing the cost for their managed care patients. It puts the SNF at a better position to address some of the concerns the hospitals have, take some of the risks from the hospital, take those high acuity patients, and still be able to reduce the cost of care for those patients. And doing this also makes more people do home dialysis. Technically, that's their home, so they're doing more home dialysis. And CMS and other regulatory agencies are putting more emphasis on doing more home dialysis, which does reduce the cost of healthcare. It's like it's something that would benefit everybody in the system. So I wouldn't want to finish the conversation without talking about the benefits for the patient. So when patients get dialysis inside the nursing home, they avoid unnecessary travel, either because of bad weather or because of just the transportation, and then coming back, losing almost the entire day to dialysis is not something a patient or a family would want to do when they are mainly there to do some rehab and go home. So it provides them the necessary time they need to rest, the time they need to do more physical therapy, time to eat better and not miss any meals. And the chances are they're more likely to do more therapy and get out of nursing home sooner, and reduce the cost, reduce the readmissions to the hospitals. And it provides the opportunity for a better coordination of care between the different entities that are involved in there. So this is something that would be a win-win situation for everybody involved in the system. I don't think there are any ambulance or transportation personnel involved. So, well, barring that, there is everybody wins in the system here. And this is about nursing home dialysis in a nutshell. And obviously there's more to discuss, and I'll be happy to answer any questions that comes up at the end of this presentation or even later. Just note down my number and my email. You can also contact Rodney White, who is a Vice President of Strategy and Development with Concerto Renal Services, and we'll be happy to answer any of your questions.
Thank you so much. I am just trying to get my paper shuffled here. So thank you so much, Dr. Sampson. Shirley, I am going to try to unmute you. Shirley, are you okay with unmuting?
We're going to let Mary
Yes, I can unmute myself. Thank you.
That's great because I couldn't figure out how to do it. We are having a day. So thank you very much. Shirley Irving is a registered nurse with a Bachelor's of Science in Nursing and is a certified dialysis nurse who works through clinical collaboration with healthcare professionals to understand the feasibility of caring for home therapy dialysis patients in a long-term care and/or skilled nursing facility. Before starting in dialysis in 1996, she worked in various healthcare settings, including med-surg, oncology, home health as a wound specialist, and with both mentally handicapped and psychiatric clients. After successfully gaining a wide variety of skills and knowledge, she started working with ESRD patients in the dialysis setting. She started in the outpatient dialysis setting in 1996 and shifted her focus to home therapy in 1998. She's a passionate advocate for patients having the best quality of life from the time their journey begins on dialysis. Life is a journey from beginning to end, and dialysis is no different. Shirley enjoys clinical collaborations that advance opportunities and knowledge about dialysis, especially home therapies, and ways to improve patient choice and care to meet the patient's lifestyle. Thank you so much, and I will turn it over to you, Shirley.
All right, so I am so excited to be here today and share my experience with home dialysis in a long-term care skilled nursing facility. We're going to discuss benefits, considerations, and training that needs to take place in this type of a clinical collaboration. The collaboration that I have had experience with has been with conventional or with more frequent dialysis. As Dr. Sampson stated, there is both conventional and more frequent dialysis that can be done in the skilled nursing facility. Next slide. So we're going to touch on these things throughout this presentation: the patient benefits, the care facility benefits, the dialysis clinic benefits, and then obviously there are state and federal benefits as well. So let's talk about the patient. The most important aspect of this is the patient, and this type of a collaboration allows for a greater continuity of care in the patient's existing living environment. This allows for the people that provide the care on a 24-hour basis to have a very good exchange of information directly before and after a dialysis treatment on the patient, and that type of clinical collaboration is very beneficial for the patient. Patients are not required to be transported outside of the facility, and this is a very big issue for the patient. They do not like getting out in bad weather, and the ability to be able to stay within their home and just go to a different room for dialysis is a huge benefit for patients who are recovering from an injury, an illness, or who have been debilitated and are trying to regain their strength. Patients tend to feel better and recover quicker. We find that with more frequent dialysis, our patients really do feel better. I may not have the clinical studies to show the benefits in a skilled nursing facility over conventional, but my experience has been that our patients who do more frequent dialysis, they have a better quality of life. They feel like they can engage more in their activities of daily living, and that is no different from our patients in an outpatient setting to our patients in an inpatient setting. So the patient benefits are relayed to us directly from the patients, and they do feel better and they do have more energy to participate. That energy does allow for greater participation in additional medical therapies such as physical therapy, occupational therapy. Many times when a patient does conventional dialysis or they go to a dialysis clinic 3 times a week, after their dialysis treatment, they feel so wiped out that when they return to their skilled facility, they either refuse to participate in their care, or their other therapy sessions are limited. Maybe they don't do the full physical therapy. And because we're able to dialyze them in their home environment, patients tend to miss less treatments than they do when they are transported outside of the dialysis facility. there's a number of reasons that patients miss treatments. One of them is that, you know, the time it takes to get them up and get them dressed and get them around and into a chair and loaded up into transportation to be transported is hard on somebody who's recovering from an injury or from somebody who doesn't feel good already. And then the thought of getting out early in the morning to go to dialysis or late in the afternoon, and it's, you know, 30 degrees outside or it's 110 degrees outside. The weather really impacts our patients a lot, and when they're already sick and not feeling well, the element of bad weather just plays into a lesser quality of life for them. So overall, more frequent dialysis is a kinder and gentler therapy for our patients. We have found that more frequent dialysis tends to act more like the kidneys do when they function. Patients do not have as much fluid buildup in their system, and we're able to keep them at a more consistent or more less fluid off, and so they tend to meet their actual dry weight more frequently. And because we dialyze them more frequently, they have less fluid as well as less toxins build up in their system. So they typically feel better overall. There's not such a big shift of fluid in a short period of time of every other treatment. And so patients don't feel wiped out. They don't have the hypotensive episodes. They don't have the leg cramping that they sometimes will experience with conventional dialysis treatment. And I say they don't have them, so what I should say is they are either absent or much less frequent than what they have with conventional dialysis. So long-term care, the benefits to the long-term care skilled nursing facility, they are able to accept more patients that require dialysis. In all of my conversations with skilled nursing facilities or long-term care facilities, they've always shared that they limit the number of patients that they can take that require dialysis because of the additional staffing requirements to get them up and around and get them transported outside of the facility, the additional responsibilities that it takes, and so that they just don't have the staff for that. And so this doing dialysis in the facility has created the capacity for them to actually care for their patients in their home, and therefore it decreases their staffing burden outside of the facility. I know that Dr. Sampson already talked about the transportation requirements. If you think about it, there is 13 dialysis treatments that a patient goes to a month in a conventional setting outside of the dialysis clinic. So that's 26 treatments a month to get one patient transported for dialysis. While you're dialyzing this patient in their home setting, it decreases your transportation needs to either no need outside of the facility or 2 trips per month. And I say this because in the facility that we work with, our physicians round at that facility, so the patients do not have to leave the facility. We can go and do their monthly meetings in the facility. The only time that a patient would be required to be transported outside of the facility is when they're coming for a clinical physician meeting. And since our physicians round at the facility, then that requirement is not needed. In some settings it will be needed, but in the ones that we work in, it's not needed. And patients feel better, so they actively participate in those additional required therapies, which thereby qualify them for longer skilled days. We were talking about many of our patients go to the skilled nursing facility for rehabilitation, and when they don't feel good and they're there under physical therapy rehabilitation and they're not participating, then they're not able to progress in their health, and therefore their qualified days may be decreased. We already talked about the staffing requirements to transport patients off-site, and if you could gain back 2 to 3 hours of your staffing by being able to keep them on site instead of transporting them, it creates greater capacity for you to meet patient needs at your facility. In COVID, we learned a lot of lessons, and what a benefit it was that our patients did not have to be transported outside of the facility for dialysis. Because at the facility that we work with, when a patient was transported off-site for any reason, then they had to come back and be quarantined. And if you're for a period of days, and if you were going off-site 3 times a week, that was practically living in quarantine. So we found that being able to dialyze them on site was a great benefit to the skilled facility as well as to the patient's overall health and lifestyle, because there was less quarantine required. And we've talked about the greater continuity of care and clinical collaboration that is provided when we're right there in the facility. If you have a patient that's having a bad day, if you've had a patient that had a bad night, we're communicating on a daily basis with the care providers for that patient. And we let them know if the patient had a great treatment. We can let them know that it was an uneventful treatment, the patient felt good, was interactive during their treatment. If we noticed that the patient didn't feel well, was complaining of symptoms or complications throughout the treatment, we could let them know right then and there. And so that greater continuity of care ensures that you have good care continuously going forward. So the dialysis clinic benefits, for us, we see overall improved quality outcomes for our patients. They don't miss treatments, therefore their fluid is more contained, more controlled, and they achieve their dry weight without getting fluid volume overloaded. We find that their anemia outcomes are better because their blood is not diluted with excess fluid. They have good. They don't miss meals, they don't miss treatments, and therefore we see overall better quality outcomes. There are fewer hospitalizations, and when patients remain in their home as opposed to in the hospital, they don't miss their medications or their anemia medications. They get their treatments done. Just overall quality benefits are derived from doing on-site dialysis. And there is a decreased cost to deliver the care. We've talked a little bit about that. Anytime that you can decrease hospitalizations, your cost of delivering overall care is less. If you've cut out the cost of transportation, and then you've also cut out a cost of care. And the patients, they feel better, they are more active, they recover quicker. These are benefits that we've seen on a personal level with our patients. And then again, we've talked about the improved clinical collaboration that exists. It's really good to be able to understand how the two go together, and you know that the patient is, you're communicating the care of that patient on a daily basis, so everybody's aware of any specifics that are needed to be addressed. So let's talk about the setting considerations in the long-term care or skilled nursing facility. We have contracts for PD patients as well as for HHD patients, and the considerations are just a little bit different, so I'm going to touch on those. For PD patients, they typically dialyze at night, and if they're using a cycler, they will need to have access to electricity because the cycler needs to plug into an outlet, as well as have some type of an area for them to drain their effluent into. There are bags that can be used so that if you don't have a drain close by, they can drain directly into a bag, and then at the end of their treatments, you can take and dispose of that waste properly. A dialysis den is optimal for the HHD patient in a skilled nursing facility. Again, the space needs are approximately about 250 square feet, and you will need access to both electric and water as well. This space can accommodate up to 6 individual stations in a dialysis den. The dialysis den will also require storage, and we've found approximately 100 square feet that has access to both electric and water, works, and we can manage up to 18 patients PD supply or patient supplies in this area. Obviously, the electrical outlet and water box is needed at each patient station, and you can connect 2 different machines to 1 water box, and so a 4 outlet receptacle would be needed to manage 2 stations. And then when you're thinking about PD patients dialyzing at night, you have to have the supervision of a trained dialysis person once the patient goes on the machine. I'm talking about a trained dialysis, not dialysis nurse, but a nurse who has been trained to monitor that patient that is on dialysis. And so if you are able to create a wing or a hall where you put all of your peritoneal dialysis patients, it creates for a better workflow, and it creates for staffing that is easier. One nurse can monitor 2 or 3 patients or additional patients if they're all on the same wing, whereas if you have a nurse dedicated to different wings, it'll be more of a challenge. You'll have to have multiple people that are trained and on site to provide that care. And then easy access for emergency personnel if needed. This is just something to take into consideration when you're creating a dialysis den or when you have a patient that's doing peritoneal dialysis in your facility. You want to make sure that if there is a medical emergency, getting people in to access that patient and be able to transition them from a bed or a chair to a gurney if they need to be taken out of the facility, that you've allowed space for that to occur, and you have a working space if that need arises. So I just included some pictures of what an actual individual patient station looks like. There's the machine that is the dialysis machine, and it's sitting on top of what we call a pure flow, which is batch dialysate that is made for an individual patient. And in this particular den, they did go to, they created it so that each patient had their own TV while they were dialyzing to help pass time. And then you see the dialysis den is a 6-station den, and this is just an overall picture of how that 6-station den is set up. This is another view of that 6-patient station den. So they have 5 chairs on one side, and then they have 1 chair on the other side. And then you can see that from the view from the nurse's station is that they have a line of sight to all of the patients, and then they have their medication cart and stuff right there where it's easy access, and they still have a line of sight to the patients at all times. In our facility that we do this type of HHD dialysis with this machine, we have an electronic medical record that we use, and we use an iPad that captures the treatment data, and then it downloads it into the medical records. So the patient can have their data reviewed by our home staff on a daily basis. And this is just the way that we store and charge and secure those tablets that maintain our patient treatment information after the treatment is over. And then this is a picture of the storage room, and you can see behind the machine that has the cover on it, there is a water box there, and that allows us access to water and electricity so that we can create that batch dialysate. It takes about 6 to 7 hours to do that. So after we do a patient treatment, about every 2 to 3 days, we'll make a new batch of dialysate, and that allows us to create that in the supply storage room. And then when it's batch made, we can test it and take it to the treatment floor for the patient. Some training considerations. You know, when you enter into a an agreement with a skilled nursing facility, you need to make sure that education is #1 priority. Once you have that agreement in place, you have to do general education to all of the staff. It generally takes a couple of hours. Typically, how we have done it is we have done 2 to 3 days where we had these sessions to be able to capture the staff that work all 3 shifts in the facility. And the education covers from CKD through ESRD and the different stages, the signs and symptoms of renal failure, what the different treatment options are, the type of infection control you need to take into consideration. And this kind of education is completed initially with any new agreement with any facility. And then there is a quarterly education that is provided to the facility and their staff on an ongoing basis. And it may be a general overview, it may be a more specific deep dive into infection control, it may be education related to patient outcomes, but all of it is pertinent to the care and the continuity of care and the clinical collaboration between the dialysis facility and the skilled nursing facility. We also do additional training and skills validation. So any staff member who is going to be responsible for the oversight and or hands-on care of either a PD patient or an HHD patient during their treatment has to have training that is equivalent to that of what we would do for a care partner for a home patient. And so that means they would have to have a competency where they have are able to demonstrate understanding and knowledge about providing that oversight or that care, as well as a skills validation. And that is typically done on all of the staff that the facility has designated as the people that will be responsible for that. And then we go in and do a group training with them, but we do individual skills validation and competencies on each one of the staff members. And then there is training and skills validation that is done with any new patient. So if I have Tom in your facility and you've been doing peritoneal dialysis with Tom, and you have a skills validation for Tom, when we admit Betty, we would still come back and validate that you understand how to do Betty's care and ensure that you have the skills and the competency for that care as well. And then there's lastly 2 models to consider. One is a dialysis staff-assisted HHD model or a skilled nursing facility staff-assisted HHD model. And we actually have had experience with both, where the skilled nursing facility provided the staff and we did the training and oversight of the staff as they delivered the care to HHD patients. And we now have a facility where we actually have a contract to provide dialysis trained staff to assist with the HHD in the facility. This is just a picture of the HHD and PD supply and storage area. There are specific requirements on how you store supplies for patients and where you keep them. And this is just a way to demonstrate, this is approximately 100 square feet, and how we have organized it to benefit the storage of supplies. And I have just included some Fresenius resource contacts. If anybody is interested in this model or having further discussion, they can reach out to either Mike Forrest, who is our business development person, or I would gladly take your call and have that discussion with you. Thank you very much for your time.
Thank you so much, Shirley. We're going to transition over to Glenda's presentation. I suspect that we will be going over. I do apologize, and I appreciate all of your patience with us. And we will be getting the slides and the recording out to everyone. So if you can't make it through the end, feel free to refer back to that information that we'll be sending out via email. Let me get over to Glenda's. Glenda, I just want to check to make sure you're off mute, and then I will introduce you.
I believe I am.
Oh, thank you so much, Glenda. Glenda Payne is a master's degree, has a master's degree in nursing and more than 40 years experience in ESRD. Early clinical experience included work in peritoneal dialysis, renal transplantation, and later as a renal clinical nurse specialist and clinical research nurse. Previous work experience includes the Texas Department of Health as a surveyor and the Centers for Medicare and Medicaid Services, where she was involved in changes made by CMS survey processes, the ESRD conditions for coverage, and interpretive guidance. She was a member of the core faculty for every CMS's ESRD surveyor training from 1989 to 2011. Leaving government since 2011, Ms. Payne served as the Director of Clinical Services for a consulting service, Nephrology Clinical Solutions. In 2018, she co-founded the National Dialysis Accreditation Commission, an accreditation organization with CMS deeming authority for outpatient dialysis services, and serves as Chief Compliance Officer. Certified as a nephrology nurse, she is active at the local, regional, and national levels of the American Nephrology Nurses Association, including serving as president of ANNA from 2012 to 2013. Thank you so much for your time, Glenda, and I will turn it over to you.
Well, I don't intend to cover all this in 4 minutes. So I'll try as quick as I can, but I want you to have the information that you need. Many of you that work in nursing homes, probably your first question is, what do you mean I'm going to get surveyed? And what I would do as a state and then a federal surveyor when we had these programs to look at was start assuring the nursing home director of nursing that we were not there to survey them. So that's not the point of the state or accreditation organization that comes in to do your survey. They're really looking at the service of dialysis that's being provided on site. So what you would expect of a survey in the long-term care setting for home hemodialysis or for peritoneal dialysis would be that the personnel that are actually delivering the care would be interviewed, patients that are being dialyzed would be observed, patients and families, if they're available and able, would be interviewed as well. And then certainly the area where the dialysis treatment is occurring will be inspected. The surveyor will also review the clinical record of the patient, the dialysis record, as well as parts of the long care record to look at that coordination of care that each of the previous speakers have mentioned is so critical. Also looking at equipment maintenance records, so that whatever type of equipment is used, whether it's a conventional dialysis machine or a more frequent dialysis setup or peritoneal dialysis, as has been mentioned, some of those treatments require cyclers, which are also machines. So all that maintenance record needs to be looked at. Monitoring logs and quality oversight for water treatment and dialysate delivery systems. Obviously, those are for hemodialysis. But water is a very important part of a hemodialysis treatment. That's what the dialysate is made from. That's the fluid that the patient's blood actually is exposed to through a very thin membrane. So it's really critical that that dialysate be safe, and that starts with safe water. Next slide. So to decrease...
it's coming in from all over.
Really? So on the blue part slide, you'll see a CMS memo is referenced, and someone asked in the chat earlier where the regulations were for dialysis in nursing homes. And the CMS conditions for coverage don't actually address in the regs themselves dialysis in nursing homes. But it has been mentioned there are some guidance documents. First, there was a letter written in 2004, which is antiquated and is based on the old regulations. The regs were updated in 2008. And finally, in 2018, a mere 10 years later, CMS did issue a state operations manual, and that's included in this memo, QSO 18-22. If you were to Google QSO memos or survey and certification memos, CMS, you'll get to a page on a website that will allow you to screen for a particular interest, and you could type in ESRD and then look for 1822. And that's a fairly long memo, It's a PDF that you can download, and it does address dialysis nursing homes. So in order to decrease your risk for surveys for patients that are receiving care and dialysis in nursing homes, as has been mentioned by both the speakers, it's important that qualified personnel administer, monitor, and supervise the dialysis treatments. And that also includes monitoring the patient both before, during, and after dialysis, and then being sure that the environment is safe and sanitary. Certainly in this time of COVID, as has been mentioned, we really need to be careful about infection control. And anytime care is being observed, hygiene is often as a missing element. It's very easy to skip a particular time of hand hygiene. Next slide. So we want to talk about some goals for dialysis care. One of the things that is required is if dialysis is occurring in the nursing home, there has to be a written agreement between the nursing home and the dialysis provider. If the patient is leaving the nursing home to go to dialysis in an inpatient center, then there does not have to be a written agreement. But if the dialysis is happening in the nursing home, there has to be a written agreement. That has to spell out who's responsible for what during the treatment, before and after. And the ESRD, no matter who's providing the dialysis, whether it's the dialysis staff or nursing home staff, the ESRD facility is responsible for the dialysis-related care and services. And all the services have to meet the ESRD conditions for coverage. It's expected that home patients, whether in nursing homes or in their own homes, receive the same level of care as an in-center patient. So, and then the agreement spells out also has to be met, more or less like a policy and procedure, for instance, that you always have to meet those, even if they are more stringent than the actual regulations. Next slide. So we've talked a little, both the previous speakers have talked a little bit about payment. In order to receive payment for the dialysis itself, the ESRD facility has to be certified as a home dialysis program. So if you're going to be doing home hemodialysis, you have to be certified for home hemodialysis training and support. If you're doing PD, you would have to be certified as a peritoneal dialysis home training and support. If you're doing both, you'd need certification for both. And then the oversight of the dialysis itself in the long-term care setting is through the certified hemodialysis program. And surveyors are required to visit one or more long-term care settings where home hemodialysis is being provided. Or if peritoneal dialysis is being provided, again, the surveyor is expected to visit at least one and perhaps more long-term care settings where dialysis is provided. Next slide. I've mentioned already how important water is, and obviously the long-term care setting, then you have to meet the water and dialysate standards that are in those conditions for coverage for ESRD. And each of us has mentioned how important communication is between the long-term care staff and the dialysis staff. Before COVID, I would say March of 2020, it was understood that every single patient had to have their own separate machine, whether they were in a nursing home den setting or in a private home and just one patient there. When I worked for CMS, and for that matter, when I worked for the state, it was our understanding that that was a reimbursement regulation, but that was clarified in one of the first universal waivers that was put out. That the waiver said that there was no requirement for one-to-one machine, and it turns out that there isn't a reimbursement requirement that has been completely and totally checked out, and it is not a requirement anymore. So that's really a good thing, particularly for nursing homes. You don't have if you have 12 patients, you have to have 12 machines. Perhaps you could do it in a den and have only 4 machines and have 3 shifts. And that's a lot fewer machines to maintain and keep track of and be sure that everything is all okay. Next slide, please. So the ESRD responsibilities in the long-term care setting include being sure that all the personnel who administer dialysis and who supervise care are competent. And we've mentioned already the necessity to have skills checklists and to be sure that you have good personnel files that support that the people that are doing the work are qualified. And then the ESRD, as I mentioned, is responsible for the quality and safety of the dialysis treatments and the management of any ESRD-related conditions. And then, of course, the equipment itself, that's the ESRD's responsibility. Next slide. And then the long-term care responsibilities. Okay, what are you as long-term care providers, what do you have to be responsible for? You have to provide a safe environment for dialysis treatments. First of all, you need to monitor the resident before, after, during, and after dialysis for possible complications. Provide emergency support during dialysis. We mentioned the need to have space to get emergency equipment in. Many times the dialysis staff will be a single person there with the patient, and if there was a need for emergency care, then the long-term care staff would need to step up and provide that emergency assistance. That should be spelled out in that written agreement we mentioned. And then assistance with supportive care, such as helping the patient get weighed before their treatment and after their treatment, working with the dialysis provider to understand the fluid and diet restrictions, and working with the patient to help the patient adhere to those restrictions without being seen as unduly restricting that patient. And then vascular access surveillance is important as well. All of these patients that are on dialysis have to have a way to connect to the dialysis machine, and so vascular access is critical, and that would be included in the education provided to the long-term care to certainly be happening from the long-term care staff. And then obviously all non-dialysis care is the long-term care center's responsibility. Next slide. Collaboration we've mentioned and how important that is, and that's the shared responsibilities really between the dialysis service and the long-term care setting. We've mentioned robust communication, and these are some of the ways that would happen. Certainly the orders would be clear, medications, some would be given during dialysis, some are related to dialysis but would be given afterwards, such as phosphorus binders, for instance, would need to be given with all meals. And then patient assessments and handoffs. Critically important that when the dialysis is completed, that the staff that are going to be taking care of that patient understand if there were any issues during the treatment, as well as important for the dialysis staff to know, what kind of events might have happened to the patient. In outpatient centers, sometimes patients come in and they've fallen and they don't recognize or know to tell. Ask about that. And if there's been a recent fall and the patient has given heparin, they could have a severe and really consequential bleed. So it's important that what has gone on when you were not there as the dialysis staff is shared by the long-term care staff. Both dialysis facilities and long-term care facilities are expected to have plans of care. So in addition to the mention of the QAPI that is collaborative, so are the plans of care. Certainly things that are needed in the nursing home are separate and distinct, but there are also some that are, and the same is true for the ESRD plan of care. Then the training, and I think we've had a good discussion about the training that's necessary and how that gets competency tested so that you're sure that the staff member is able and qualified to care for individual patients as you switch between one patient or another. Next slide, please. So this is my contact information in our company. As was mentioned, we do have deemed status from CMS, so we do both initial surveys in lieu of the state, and we also do additions of services. Right now, there are a lot of clinics adding home services, so that's something that we do too. So you're welcome to contact me at either my email there or information on our website. And I'm sorry to rush, but got us through almost on time. So there you go.
Thank you so much, Glenda. And thank you everyone who is still with us on our webinar today. I know we did go over and we do apologize for that. The recording for this session as well as the slides will be made available after. We do invite you to contact any one of our speakers. The network's contact information is here as well. This program was provided and coordinated through Roma Heater. She is our Quality Improvement Manager of Qsource ESRD Network 12, but you can contact any one of the Qsource offices. We do also invite every participant to complete the SurveyMonkey link that you see on the slide screen. This will be how we are going to give credit for people who have attended. So we do want to hear from you. And for all of us from the ESRD Networks program, we just want to say thank you for joining us today. Thank you so much for all of our speakers. And I wish you all continued health and wish you a wonderful Tuesday. And thank you so much for joining us today. Have a good one. Bye-bye.
Thank you.